Hi, everyone. We'll get started in just a few minutes. In the meantime, if you'd like to introduce yourself in the chat, we'd love to see where everyone is joining us from. And if you're also feeling up to it, feel free to go ahead and share some initial thoughts on the use of AI, ethics of AI for behavior change, any experience you might have in the chat as well. We'll have some time for an open discussion later on in this call, but always good to have a bit of a warm up and start thinking through some of the issues and questions around this topic. So please feel free to use the chat. Okay, let's go ahead and get started. I know people are still joining us, but want to make sure that we have enough time for some discussion at the end. But hi, everyone. Thank you all for joining us today. In this webinar, we'll be focusing on this topic of leveraging human-centered design and AI systems for behavior change and health. This webinar is co-hosted by the Global Handwashing Partnership and USAID Momentum, but I just wanted to quickly introduce myself. My name is Erin Palomares. I'll be serving as today's moderator. I also manage the Global Handwashing Partnership Secretariat. And for those of you who haven't heard of the Global Handwashing Partnership before, we are a public-private partnership that serves as a global advocate and knowledge hub for hand hygiene programming. Our secretariat is hosted by FHI 360, and we have a list of our current partners on the screen now. But as part of our role, we try to host regular webinars around key hand hygiene topics. And we've been working with USAID and Quicksand over the past couple of months around this webinar, and we're excited to have the Quicksand team with us today to share an example from SafeHands, a project that was implemented under USAID Momentum for today's webinar. So just some quick housekeeping. Please do keep your camera and microphone off for the presentation portion of this webinar. We will have some time for open dialogue at the end, so we'll open it up then. And then during the open discussion, please just raise your hand or turn on your video or some way to indicate to us that you would like to speak. We'll be sure to call on you, and we'd love to hear your perspectives throughout. Please also post any questions you have in the chat. There will be some time for general Q&A before going into that open discussion. I'll try to compile a list of any questions that are posted, and I'll also try and answer any questions that I can answer directly around logistics or technical. But for any questions to the presenters, I'll go ahead and start compiling those. So please do post them in the chat. And then finally, this webinar is being recorded. So the recording will be used to just capture any insights from our discussion to include in an event summary that will eventually be available on the GHP website. And then just a quick look at our agenda. Up next, we'll have some opening remarks from Nanwen, who is a senior advisor at USAID, followed by our main presentation by the Quicksand team. And then again, we'll have ample time for Q&A and open discussion at the end of this webinar, because again, we'd love to hear some of your perspectives and thoughts around this topic. And so before I leave you, I do just want to throw this question out there, get you thinking a little bit, and I'm sure this will come up in the open discussion again. But as you're listening to the presentation, just keep in mind, what would you keep in mind from an ethics perspective if the SafeHands project or a project like this was going to be implemented in your country? So with that, I would like to introduce our first speaker, Ms. Na Nguyen is a senior WASH and social and behavior change advisor at USAID. She also serves on the Global Hand Washing Partnership Steering Committee and has a wealth of expertise and ideas around behavior change. So Na, I will pass it over to you for some opening remarks.
Great. Good morning. Good evening, everybody. I'm so happy to see everyone here. I feel like it's been a long time since the hand hygiene community met online now that COVID-19 has been declared over, though I do know people who are still getting COVID, some colleagues of mine. So I think, even though COVID-19 is over, the pandemic is over, we are still searching for the unicorn solution, right, to sustain hand washing with soap. I think at USAID, we have been a longtime supporter of promoting hand hygiene, as we were one of the founding partners of the Global Hand Washing Initiative, the partnership in 2001. So over the years, we have supported many approaches to behavior change, including communication, but also funding studies to look at nudges in schools. And now we are looking at potentially nudges to help hand washing during food preparation in Ethiopia, Malawi. So the search goes on, but beyond hand washing communities, USAID also investigates or invests in infection prevention control initiatives in healthcare settings. So the work includes, among others, an activity that we will be exploring today through the USAID Momentum Health activity that really looks at hand washing compliance and the use of artificial intelligence. I think the work is particularly timely, but also really interesting for me as a behavior change and hygiene practitioner, because this study brings together not only sort of behavior change, human-centered design, but it also brings together technology in the form of the hand washing device. And then it also raises issues of ethics, right, and compliance, and the use of AI in various settings. I think we always think that hand washing with soap is a behavior that should be fundamentally promoted in many settings, but how we do it, right, and the use of AI, I think brings in the questions of ethics that we have not had to really explore or unpack when we think about hand hygiene. So with that, I'm going to hand it back over to Erin to introduce our guest speakers, and I look forward to discussing the ethics and listening to your questions after the presentation. Thanks.
Thank you, Na. And again, we're excited to have the Quicksand team with us here today. As Na said, I think this really is a very interesting case study for us to look at and spur some discussion throughout this call. So I'm honored to introduce the Quicksand team. First, we have Rishabh Sakdeva, who is the principal at Quicksand and has over 15 years of experience in bringing culture, systems, and technology together to work with human-centered design. We also have Yoshi Shah, who's an independent researcher and writer. She has been working with Quicksand for more than 2 years on their project in the social sector with special focus on health, technology, and data systems. And we also have Arshmin Bavaja, who is a senior design researcher at Quicksand and has a background in computer science engineering. Her work revolves around applying human-centered design and behavioral science in tech-related public health projects. So I will hand it over to you all to present the approach and insights from your project.
Thank you, Erin, and thank you, Na, for that wonderful introduction. I'm sorry I can't switch on my camera today because of poor internet, but I hope I more than make up for it by talking you through our project. So just a word about Quicksand Design Studio. We are based in India across Delhi, Bangalore, and Goa. And we typically use design and design research methods to build people-centered products, services, systems, strategy. So that's a little bit about us. And I'll dive right into this project that we want to talk to you about, which is the use of artificial intelligence and human-centered design for behavior change in health. Ashmin, if you could move to the next slide, please. Right. So these are the topics we're going to cover today. I'll talk a little bit about our project, but we're most excited to hear from you as well, which is the discussion session that Aaron has already gestured towards, where we will speak about replicability, sustainability, and most importantly, ethics. If you could go to the next slide, please. Right. So about our project, I think the problem we were trying to solve is one of hand hygiene. Like Na said, it's crucial, but at least in health settings, the compliance for hand hygiene protocols is not as good as one would hope for it to be. And this is actually a challenge world over. It's not specific to low middle income countries. And typically they try to use supervision or feedback, where your senior might actually pull you up for not following the protocol. But those are prone to bias, right? And they are resource intensive in the sense that they take up your time. So through this project, we wanted to explore if some of that can be eased through a new technology like artificial intelligence. And our project brief was actually quite simple. If you could go to the next slide, please. Right. So what we were trying to do is use human-centered design to explore if AI can be used to improve hand washing in the labor rooms of India's public health facilities. That's also because there's not enough literature on how a technology like AI can be used in these settings. Most of the research has been conducted in bigger countries from the global north. So yeah, so that was what we were trying to do. Um, a little bit about human-centered design, because we realized that the audience may be from varied backgrounds. So HCD is really just a creative way of problem solving, where we start with qualitative research, and this can be quite in-depth, where we try to understand people's needs, preferences, hopes, fears, and so on. Uh, Through which we very quickly build certain rough solutions that we aren't the judge of, but we take it back to the ground for feedback, so that we hear from people early on and throughout. And through their feedback, we can keep improving whatever the solution may be. Like I said, it can be a product, service, system, strategy, and so on. Um, and that's why co-creation turns out to be a cornerstone of the HCD method, where you build together, which of course increases the likelihood of uptake and adoption, but it also lets you fail at a smaller scale, which means that you save resources in your project. Like otherwise development projects can happen at a larger um, I mean, across multiple settings, and yeah. So if you follow the HCD process early on, it just helps you scale in a more manageable way, because your solutions have taken your people into account right at the start. So that's a little bit about our process and how we situate ourselves within the development sector. If you could go to the next slide, please. Right. So now coming to the project itself and how we applied that approach to hand hygiene and AI. So we were working with an AI device called Hands, which has two components. It has a display device that's typically put above the basin, where you can see the screen, the picture that we have shown on the left. And as you do the 9 steps of the WHO protocol, the camera can recognize your hand movements. It can't see your face or any other identity markers, but it only focuses on your hands and gives you an evaluation at every step, which we call real-time feedback. And that information is aggregated and presented on a dashboard in an anonymized way on a daily basis. This is meant to help the managerial cadre to monitor and supervise hand washing better at the ward level. So again, there's no point at which you would get individual disaggregated data just for privacy reasons. So these are the two components of the AI system we were working with. If you could go to the next slide, please. Yeah, and we were working across three states of India: Chhattisgarh, Jharkhand, and Madhya Pradesh. We've just mapped out the facilities for you. And I think that what would be useful to know is that the district hospitals are slightly larger than the sub-district hospital and the community health center. So there is a diversity in terms of scale and geography. And the project itself ran for 12 months from July 2021, which was when the pandemic was still a threat, to July 2022. And I think despite the diversity, one thing that's common across these public health settings is um, resource constraints. We've tried to sum it up with one quote that we've heard from our respondent, where in a night you can have, anything up to 19 deliveries with only 3 staff on duty. So that hopefully gives you a sense of um, um, the urgency with which they may be working at some times of the day. So if you could go to the next slide, please. Right, now coming to our approach, I'll be covering it in 3 ways. Actually, me and my colleague will be covering it three ways. We'll talk about our research, about our synthesis and co-creation, which I called like the cornerstone of HCD. The next slide, please. Right. So, I mean, we usually use like qualitative and creative methods. So, at the back, what you can see is a transparent images. Some kind of, it's a map of one of the labor rooms where we're working, with the hand hygiene supplies colored up, which gives you a quick visual idea of access and availability, which I'll be able to explain why it's important. There's another picture of like a focus group discussion which we were covering, and I think third, we just put the mobile because we also wanted to emphasize how the project started during COVID, and so some of our relationship building actually started virtually, right, where we would have to broker trust over WhatsApp and over phone calls, and also use the network efficiently. So some of the staff members didn't have a smartphone, so you would typically ask the labor room in charge or the nurse to facilitate the call between you and that last person. So it was also a learning. We've not written too much about it, but I just wanted to point to the circumstances in which this project started. The next slide, please. Right, and then just coming to a few voices or stories from the ground. So, what did we learn, or what did we hear through that qualitative research which we conducted? So, very often you would, you would hear that we don't have the time, we can't attend to patients and wash our hands properly. Um, you also heard how hierarchy plays a very important role in these settings, where people may even make mistakes with the protocol only because they're scared of the person who's supervising them. At the same time, there were more positive aspects to their work culture, where if they would help each other learn the protocol if for some reason someone has not been able to attend the training and refreshers. um, so that's a little bit on this slide of the stories that we wanted to share. Um, and yeah, if you could go to the next slide, please. Right. Then the other set of voices were around the protocol itself. So one thing we learned is that there is a local version of, or a local variant of the WHO protocol that's very popular in some hospitals across northern India, which is called Suman K. So people initially wondered why the AI system has to follow something they're not used to, right? And Like I said, because the patient load can be higher and there is a shortage of soap in most of these settings, usually they find gloves or alcohol-based rubs easier and more convenient. So this was another challenge we were looking at in terms of hand washing. and also a discrepancy or like an inequality in who gets training. So very often, I'm not very often, but sometimes the nurses would be sent, but the non-medical staff and the paramedical staff wouldn't get as much attention. There were also misconceptions that just wringing your hands makes for a good hand wash, like you don't need to follow all the steps of the protocol. The next slide, please. Right, and like thinking about, what then makes you pay attention to hand washing against the extreme circumstances in which you're working, where you might not have soap, you may have too many patients to attend to, you're scared of your seniors. We also heard very human stories of people actually having lost their colleagues during COVID, which made them more careful about protocols, just their safety and the safety of their loved ones. And also this interesting fact that usually they become more diligent about hand washing when there is an external assessment due. So when you have someone who's going to come in and see you is when you start paying closer attention to the protocol. The next slide, please. Right. So like we tried to give you a sense of the breadth and depth of stories that we heard, and we actually did have to sit back and think about how to synthesize our research, which is when we were introduced to this very useful tool, which you all can take a screen grab of. It's the Man of Groups toolkit for behavior integration, which allows you to think about your research in a more evidence-led and linear fashion, because there's always the risk of jumping to ideas and sort of interventions, instead of being behavior led, right? Like we very quickly think of solutions before even diagnosing the problem thoroughly. I've not elaborated on it over multiple slides, but just to say that all that information actually came down to just a couple of insights, which can be broken down this way. There was the question of right knowledge, where there can be a lack of awareness about the WHO protocol, because of which people weren't able to wash their hands properly. There can be a lack of evidence as well. They rightfully wanted to know why WHO compares better than Suman K that they were used to, or any other form of hand hygiene like gloving and alcohol-based drugs. And part of that is the question of competing protocols, which I mentioned how different countries, and particularly in India, you might have versions of the protocol. So, which one to follow when is the question. I think after knowledge comes the question of environment. We realized how inclusivity, or like ensuring that your training and communication is actually equitably available to non-medical, paramedical, and medical workers is important. So is cohesion. I gave the example of how the team would help each other to learn the protocol, and I think I've recurringly spoken about lack of time, which I don't need to say more on. And the last being, if you are able to address knowledge and environment, there's of course the question of motivation, right? How do you build accountability in the sense that there should be how do you build accountability and incentives in the sense that there should be some carrot and stick for you to follow the protocol, which was not very clear in our settings, except that people may be scared of COVID and were washing their hands. So I'll hand it over to Arshmeen at this point. She can take you through the rest of our work.
Thanks, Nyoshi. Yeah, so walking you through the sort of the more fun and interesting part of the HCD process, which is the co-creation exercises that we did across the project, throughout the project. So we started off with what we call in design research, the concept of sacrificial concepts, which is basically coming up with ideas on the back of the problem statement that we were given and the brief that we had, and to really just think through some of the initial sort of what has worked in the past, and maybe use some cross-learning across projects, across industries even, and to think about what, like, just to get a sense of what could potentially work. And then what we do as an exercise is that once we've done some initial brainstorming, as Nyoshi said, that we often think about solutions as permanent, but that is not the case with design research, where we would like to think of these as sacrificial, as we term them. So the idea is really to just get a sense of what ideas could work and how can we sort of discard them if they don't early on in the process. So we did some sort of thinking around, like, for example, using a framework of ideas around environmental restructuring, incentives, education, just to get a breadth of ideas and not restrict to the run-of-the-mill ideas that can sort of come up. And this was again done in collaboration with the project stakeholders, even across teams as well. And then what we had was, we sort of, with these concepts, and you see here on the right is the concept cards that we present to the people. So this is one of the sort of exercises that we did, where they can vote, they can discuss, they can debate what idea works, how can we improve the idea, because the key is like not to stick with the idea that is presented, but to better it. And there is a sort of a range of prompts and questions for each of those that are then designed for each of the stakeholders that we are working with. So the ideas for management will look very different from the ideas for the staff, for instance. So this is the process that we followed before we sort of synthesized our learnings. And then we again sort of did this in some fashion, where we got some prototypes out just to understand what could work, and before we came to our final interventions. I'm happy to take any questions on this at the end of the presentation as well. But what our eventual sort of intervention design looked like was to think about the interventions in terms of digital and non-digital. And sort of as the visual sort of explains it, both the digital and the non-digital are to be seen as something that come together to build a system. So you have an improved, so what we did was we did design an improved version of the UI for the device that I will show you in just in a minute, but also like just to think about other non-digital intervention that could potentially work in these settings, because digital is often not just the answer, it's not the single answer to the problems that we were looking at. So I will also walk through all of the sort of the interventions that we finally came up with in detail a little bit. This is sort of the improved version of from what we started on the right to the one on the left of the device with the display screen. What you see here is you still see just the hands being captured and not any other identification markers. You have an RTF process, which gives you a tick if you do the step correctly for the required number of seconds. You have easy to understand GIFs here, so they all play sequentially so that you're not really, your attention is not diverted across all steps like was the case earlier. You have clear sort of look at the time that is going on. And at the end of it, so these are some of the sort of elements that we used. So for example, if the step is to be performed on both hands, then you have a sticker which says you haath badle, which means like change your hand, and you can easily follow those instructions. And then eventually we sort of ended up with like a score at the end, which like some gamification elements that I will just talk about in just a couple of seconds as the screen video ends. So this is really to make the sort of the device a little bit more relatable, more culturally resonant, to have like a mascot, like a sakhi, which translates to a friend. So a friend who is sort of guiding you, who's teaching you, and also which can be perceived as like, a tool that can be used for self-learning. You have like sort of a score out of 9, you get your seconds, you get a comment on whether you did well or not, depending on your score, you get the time and the date stamp. So everything sort of like comes together. And if the machine is not working well, then, it's advised to sort of contact the labor room in charge and let the team know. So these were sort of the elements that we worked on for an improved user experience, which was well appreciated by the people on the ground. Then talking briefly about the non-digital interventions. So the first step that we have on the left is the performance reports. So this is, as Nyosha earlier talked about, we had a dashboard as a second component to the device, but what we observed very early on, and that sort of stuck throughout the project, is that the management did not have time to access the dashboard. So, or often they did not even have computers to access the dashboard. So what we did was we presented these sort of like short MIS reports, like 3 to 4 pages long, where we gave them the performance of what it looked like every 2 weeks. So we gave them on WhatsApp, because WhatsApp is the most common mode of communication. on the WhatsApp group where the management was there and even the staff members. So, and this was done in local language so that it could be easily understood. So what it really translates to is that the compliance rate for the last 2 weeks is 39%. With like simple, very easy to understand graphs, because often numbers don't make sense, like that was the case on the dashboard. Here is a comparison to the last 2 weeks. So what was the performance in the previous 2 weeks and the weeks before that, just to give them a sense of whether they've improved or not. So we had like simple graphs, visuals, really just to give them a snapshot of their performance. And most importantly, like providing the data back to them, because that often is not the case. They do not really get the data, and especially staff on the ground where they don't have access to data. So this was one of the interventions that was quite a game changer in the phase that we were working in. And then what we did was also prepare like a toolkit of sorts, where just to understand and learn the protocol, because one of the insights was lack of awareness. So how do we build that knowledge? And what the context that we're working in is that people have different literacy levels. So what we wanted to do was like, we prepared like a playing card game. You can see here a sketch of like, how we thought of visualize this to happen. So it's a card game where you can sort of put the steps together of the protocol of all the 6 core steps in one line. So that was one of the things that we built and was quite appreciated and was taken on quite well. The other thing that
अपनी
we
सुरक्षा
have,
के लिए बेहतर तरीके से हाथ धोना। नमस्कार, क्या आप मुझे जानते हैं? मैं जानी पहचानी लग सकती हूँ, लेकिन हमारा परिचय नहीं हुआ है। मैं हूँ सुरक्षा।
So this was just like a few seconds of the sort of orientation videos that we prepared. Like we prepared 3 short videos on the protocol, on the moments of hand hygiene, and on the device. So 3 short videos that can be played on WhatsApp very easily and can be shared. So just to give them a sense of, again, like, breaking down even the technology, the one on the Vajra hands, of what AI is, what does it mean, what machine learning means. So breaking it down in layman terms was very important. So that is something that we covered as part of the non-digital interventions around the device. Talking a little bit about the results that we achieved as part of this phase. The 6 sites that we were working in, we started off with like very low compliance, as you can see in the first phase, where it was just the device with the old user interface. And then we improved the user interface and provided the supporting interventions for about 3 months. And it jumped quite a bit. So these 2 sites, Pipari and Sioni Malwa in Madhya Pradesh, jumped up to like quite a big jump. The average jump was about 150% increase in the compliance rate. And then we did see a fall, and the fall is really in the maintenance phase, where we stopped the supporting interventions. So all the non-digital interventions were stopped, including the performance report, which definitely did have an impact. And just the new interface of the device was on for this phase where we collected this data. So this is really just putting numbers to the sort of the impact that we were able to achieve. Talking a little bit about sort of some of the themes that we wanted to discuss as part of this webinar, one of them being replicability. So just to give a little bit of context, this was the first phase of the project, which ran from July 2021 to 2022. And then we got an extension, and then this is the second phase of the project that we are in. And now we've moved into bigger sites and different sites. So I'll take a minute to sort of talk about what I mean by that. So we're looking at tertiary facilities now. So earlier we were working with primary and secondary facilities. This time we are working in tertiary, which is like much larger sort of caseload. Already there was lack of time and staff crunch in the facilities that we were working with earlier. It is even heightened in these settings. Respondents sort of describe the situation as a crisis because they do not have time to wash their hands, spare that 1 minute as well. As one of the sort of respondents says, that doctors are an expensive resource, they face so much pressure that they've stopped caring about themselves. So this really speaks to the sort of the situation and the sort of the dire situation that that is present, at least in these settings. So it's even difficult to sort of focus and emphasize on hand washing and hand hygiene methods, but it's also even more important because they're also dealing with that many patients. So how do we sort of think about the solution that we have, AI as a solution, and our focus on hand hygiene? So how do we reimagine that is really the question. The other settings that we are now working in are educational settings. So those are skill labs where students, nursing students, so nursing students are sort of like are trained on medical procedures, and then they go on to become nurses. So what we observed is that surprisingly, hand washing is taught verbally, if at all it's taught, and there is no practical module on it. So we thought that Vajra Hands is a good tool to to practice hand washing in that sense, but the actual uptake of the project has faced some challenges, and some of the challenges are really about convenience, where they're not used to sort of using a device for hand washing, and they might not even end up going to the skill labs very often. It would be a very irregular and infrequent process. So how do we address that? Even some structural constraints like infrastructure as well. So as you can see on the image on the right, where there is stagnant water in the tank up above the basin, so they do not even have running water supply. They do not have liquid soap, as again was mentioned for labor room as well. So how do you expect people to sort of wash their hands? And then really just like the trust and the compatibility with how does this fit into the curriculum that they have existing, and how do we go about it, and how do we make a seamless integration into the curriculum? So these are some of the challenges that we're still thinking through and working through, and happy to have a discussion around this as well. I'll hand it over to my colleague Rishabh, who will quickly talk about the thoughts on sustainability as well for this project. Rishabh, over to you.
Yeah, thanks everyone for joining. Just very quick thoughts on this. This is the big picture. I mean, this is the $1 million question in some sense, or whether this actually works and can this work over a period of time. Honestly speaking, we've been observing performance at some of the historical sites and some of the larger kind of hospitals in which we've installed the device right now. There continue to be sort of technology challenges for us, and both in terms of the AI being itself a new kind of technology, this being a small sample study in some sense. There are about 10 to 12 hospitals. So the data volume that we have limits the amount of training and improvement that can be done. And so a much larger amount of data would kind of improve things over time. But also just like practicalities of installing this device in public health settings, where recently one of the challenges that we faced was that the tube light above the device in one of these hospitals had malfunctioned and it needed to be replaced. And that in itself was a arduous process to kind of source one tube light. So just, yeah, the reality is that the tube light is a bottleneck sometimes for AI. And that's something to kind of consider always. And internet issues and last mile sort of connectivity, and all of these are things to kind of think about. These are realistic challenges. We also had kind of stopped performance reports to see how that affects things, and we've definitely seen people missing them, and also when we've reintroduced them, they've found resonance, and they've again sort of started the conversation within the team. But also I think the question for us is that the performance reports about hand washing are very different from a system of compliance that they had before. Compliance typically has meant an evaluator comes and tests you on a day on whether you know the protocol or not, and you can practice the protocol in front of an evaluator quite easily. And we've also heard things about like I think the team brought up earlier that there are 2 or 3 protocols in play in some of these. There's the WHO protocol, there's the state protocol, and there's some other protocol that a program is kind of introduced. And depending on which evaluator is coming from which program, people are happy to perform that particular protocol on that day. But on a daily basis, every day, at moments, and sorry about that, moments where it's relevant, that's when the practice kind of falls. I think we're also questioning the relevance of the applicability of the moments. It sounds like it's covering a lot of ground, but are those moments really practical in the kind of settings that we're talking about? And how do we actually make them relevant? It's ideal state, but it's not practical. Also, our partner on this program, Japaigo, in some of these hospitals from last year has had slightly reduced sort of ground presence, and the kind of urgency and visibility they brought to this, and the kind of salience and the importance that they brought to this has somewhat reduced. So it's the sustenance of this is back to the staff on the ground, and for them, washing hands is one of the many things that they do, and we are suddenly asking them to think about an indicator of compliance at a very high frequency on a daily basis all the time, which is very different from what they're used to and how some of the other indicators are measured. So why is such a high frequency sort of indicator of hand washing important for them is a question to answer for everyone, I think, in the field. Yeah, I'll just stop there because we'll take questions, I think, now.
Great, thank you all for sharing that. I know that this is still a big topic and there are a lot of questions still, but thank you for sharing your approach, insights, challenges, and questions with us. I like how you broke down the human-centered design process based on the problem of hand hygiene compliance, which then led to developing this intervention. And then I liked how you brought up some real challenges and questions that we still need to address around the replicability, the sustainability, and the ethics of AI. I know, we have about 20 minutes before we have to end, but I think there are a lot of good questions that were coming out of the chat. I was trying to compile them, and I know some of them have been answered, but maybe just good to go down that list. Niyushi, first question for you, and I think you hinted at this a little bit in your slides, but are there any publications available from the research that you did for this project?
No, we haven't published any papers, but we have a case study that was presented at the Global Forum on Bioethics for Research. And I think the work was also shown at SPCC, which is, I'm forgetting the full form, Social Behavior Change and Communication. I imagine there's a recording of it, but there's no academic output for this.
Is there any intention to develop any academic outputs from this?
Sorry, Aaron?
Are there any intentions to develop any peer-reviewed articles from this research, or is it going to be?
Yeah. So one of the things we didn't mention is that this project has actually got an extension, and we're working, like Ashmin touched upon it, we're working at new sites now. At the end of both the phases, if it's meaningful, we might work on a manuscript, but it's all in the offing and we're not sure.
And then can this be linked to the Power BI dashboard where we have data from the Kobo toolbox connected to? Sorry, I need to see who asked that. The person who asked that, would you like to unmute yourself and maybe just give a little bit more context?
Yeah, we are also, thank you. We are also monitoring. This is in Nepal, in healthcare facility. We are trying to monitor. We supported a municipality in developing their operation maintenance policy. So we are trying to monitor that. So this we wanted to capture data on use also, but this seems to be interesting if this can be fitted there. So I was thinking if the software, camera, and the app can fit into our existing system where we have a dashboard connected to Power BI. Where we have dashboard connected to Power BI. Power BI dashboard is connected to Kobo Toolbox. In the Kobo Toolbox, the data are periodically entered through mobile phone and automatically goes to the dashboard. So if this can also be added there, so that was the question. If it is clear.
Yeah, thank you, Lakshman. If I understood it correctly, or if I can generalize a bit, you're also asking whether this technology can speak to other technologies meaningfully, right? Like whether they can be integrated in some way. if I've understood your
Yes.
question correctly, I kind of want to defer it to Rishabh, who may be in a better place to answer. Um, as of now, it doesn't have this capacity, but I would think that it can be built in. But Rishabh, if you have any thoughts on that.
Yeah, no, I'm afraid I wouldn't know about the specific sort of integration of the two. Uh, but yeah, I mean, the data from the dashboard, the SafeHands dashboard for each, depending on what level of admin you are or what access you have to devices, that data can be made available in a format that's usually integrated with any of the common platforms.
Yeah, Lakshman also, I think Rishabh at some point put the link to DataCulp's website in the chat. DataCulp is the organization which developed the technology. So if you have context-specific questions, you could even reach out to them.
Yeah, thank you. Thank you for that. I will do that. Thanks.
Yeah, thank you so much.
Thanks.
So we have quite a few questions that have come in. I'm going to try and just in the interest of time, I'll try and skip over the ones that have been addressed either through the slides or in the chat, though I do think it's important. I know, Rishabh, you had answered this in the chat, but just the interest in pricing details of the system. Did you get any willingness to pay? Feedback from hospital administrators? Is there a maintenance cost? I know that you answered that in the chat, but in case people haven't been keeping up, perhaps just good to repeat that piece of it, because I think that's important in terms of especially replicability and sustainability for it.
Yeah, I was just gonna answer another question of that sort on the chat, but it's the price of the device is about $2,000 right now, with 1 year warranty included in it. It is per sync, so per device. That pricing, I think, is reflective of the amount of effort that has gone into the R&D and the scale of the operation right now. So the startup is DataCulp is trying to, I think, like recover some costs and efforts there. Support from this community will bring the price down, so please keep that in mind. Yeah, so I mean, I think they've also released an app recently that they hope is like one more experiment towards sort of scale of where this can go. But yeah, the price will only go down with scale. I think the willingness to pay is a little tricky because, like I said, that there have been issues on the ground with the tech. There have been some sort of like things where it's gone out of operation and that servicing has been a little difficult. Yeah, so it's a slightly complicated question at this stage, because again the pricing is slightly high for what ideally hospitals would pay for, and I think it's such an early stage thing that support from donors and support from the system is required to actually implement this at multiple levels and see what comes out of this. I think that's the only way it can sort of private hospitals, there is some interest in Bangalore and some of the bigger cities and outside of India that the company has kind of like received. But in public hospitals, like I said, sourcing a tube light is the biggest. I mean, it becomes like a challenge for 2-3 weeks, and sometimes we have had, so that's where the challenge is. So just yeah.
Thanks, Rishabh. Yeah, and I know that's still sort of an ongoing part of all of this. I know that there are a lot of questions coming into the chat. We will try, and just because we don't have a lot of time, we will try to compile these and send out a separate sheet, just making sure that we answer all of your questions. I think this is a good one to end on, but Sona had asked, what learnings are you taking forward in the next phase, any modification to the intervention design, and then we'll move on to open discussion. But any thoughts on what you're taking forward in the next phase of this project?
I think there's some comments. Sorry, is that an open question for the good center?
Yes.
Yeah, I think there's some comments around the fact that the device measures quality and not quantity. And I think the question back to the community is that WHO, for example, talks about hand washing and hand hygiene through sanitizers, right? And they've described they've given 2 sets of times to these 2 protocols, 20 to 30 seconds for hand sanitizer and 40 to 60 seconds for hand washing. In a high intensity setting with lots of these things where people say they don't have time, is 40 to 60 seconds actually the right kind of, I think that we have seen after COVID, supplies of sanitizers becoming better, availabilities of things, some of these things better. Also, although there remain challenges often on the ground in these settings, but a lot of people are sanitizing their hands. They're using alternate kind of like things. So and it's a little difficult to kind of keep track of that. We're approximately keeping a track of it with the consumption of the hand sanitizer bottles and the amount of sanitizer that's consumed per cleansing sort of like cycle. So we're taking some of that data, but yeah, it's a little difficult to track how many times they actually wash, how much hand hygiene is actually maintained, and what the intention of that hand hygiene is, of that particular hand wash. And are all moments understood as equally important, or there are some moments where the protocol is important and some moments where it's not so important? I think we're finding like a range of like ideas and beliefs on this. But yeah, I mean, I think like this is a limitation of the device. We can't track the number of like things. We would have to have something on people's hands or camera, like recording this thing all the time. And we did not want to go into that direction because that's the ethical questions with that.
Okay. Thanks, Rishab. And thank you all. Thank you, Niyushi, Rashmin, and Rishab for sharing your perspectives from this project. Again, it's really interesting to hear the insights that you came up with, but then also the challenges, because I think, again, this is still an emerging field. And so there are still a lot of questions on how to take technology like this forward. I want to use just the few minutes that we have left to open up the discussion. And again, we know that this is such a big topic, and so we're just interested in hearing some of your insights or experiences or thoughts. I've already seen a couple of really interesting thoughts and suggestions in the chat. But yeah, really just a space to open up for any sort of broader questions around the use of AI and the ethics of AI, again, bringing it back to that question that we had asked in the beginning. So please just, again, raise your hand or turn on your video to indicate that you'd like to speak, and we'll give everyone, the next couple of minutes to just sort of open it up.
And as people sort of like come up with that, just one small thing I just wanted to add, that in all the hospitals that we went to, I think the administrators would have loved if we had actually tracked people on an individual basis and given them names of people who are complying and not complying, and that would have definitely sort of taken the compliance levels up. But we don't want to get there. Every single customer, every single institution, the staff and the admins have different points of view on how this device should be used. Admins want, and senior managers and doctors want as much data as possible at an individual level, perhaps, and the staff reflect the realities of their daily lives.
Yeah. Thanks, Rishab. Thanks for that note.
I'd like to add to Rishab's point, because we found this quite a rich question, and that's because in a lot of data systems, we automatically assume that anonymity is a safer option, but there were fewer voices, but people also said how anonymized data, sorry to contradict you, Rishabh, but that's not my intention. It's just to give people perspectives that anonymized data can put you at different risk, where you are blamed when you aren't actually at fault for lower compliance. And so one of the things we've been talking about is to zoom out a bit, and through the human-centered process actually understand threat perception in different communities, because it differs, right? These hospitals are hierarchical, and like Rishabh said, the managerial staff will think very differently from those who actually are on the ground providing medical services, and you're likely to hear these contradictory views. So one is probably thinking about more foundational work on studying threat perception. And second, also investing in like protective systems or safeguards, because like the health technology sector is growing in an unregulated way in India. At least we don't have laws for this yet. So these are just things to add to his point. The fact that you'll hear many opinions, but how do you take those opinions and actually build a system that works for people from the perspective of protection and privacy?
Yeah, thanks, Neoshi. That's a good point. And I know that there was a little bit of that in the chat, I believe, as well. I know we just have about 5 minutes, but does anyone have any? I mean, I think that there's a lot of really good discussion, questions, again, comments in the chat. Would anyone else like to add on to that, to make another point around this topic? I think that there is still that large question of ethics around AI, and like Yushi said, sort of the safeguarding piece and regulation aspect to all of this. So, certainly really interested to continue these types of discussions moving forward. I do just want to give one last chance for anyone who has any comments, but I will say we will, I'm flitting back and forth between looking at my screen and looking at the chat. And there's certainly a lot there, so we'll be sure to extract the chat and make sure that we're including all of these really interesting points that are being brought up in the event summary.
Aaron, I'm actually just going through the comments, and there's there's a comment by someone called Mr. Gerard, who has spoken about their work around building up proxy metrics for the quantity of hand washes per shift. If we have 2 minutes, I think the Quicksand team would love to hear about this, because it's a missing piece in our own work and we could learn maybe.
Yes. Gerard, would you be willing to unmute and speak about your experience?
Yeah, I can. So we've done a work in AI for monitoring hand washing since about 2006. And the work has been published in the American Journal of Infection Control. Our studies were done in first world settings. So they were done in the NHS in multiple different studies. So we did look at trying to gain an insight into how much hand hygiene was happening. So we were tracking the amount of staff on the ward. It was a surgical ward, on the surgical ward for each shift, and the load of patients that were going through. And we tried to get a proxy metric. So for example, during the week, there would be a large number of patients and a large number of staff, and at the weekend, it would be less. Obviously, in a labor ward, as in your studies, you wouldn't have quite that level of control. But we've done a lot of studies over the years in these technologies, and the ethics issue is one of privacy for the staff. But the other ethical side of this is we did notice what we called splash and dash, which was people doing like a 5-second hand wash, which no matter how good your technique was not going to be good enough. So, there was an ethical issue of that person was placing people at risk. So there was a patient safety issue. So we've done an awful lot of research on this area, and we have technology available in SureWash, both as apps and as machines for training. Our work on co-design has very much pushed us towards the training being a very important aspect.
Oh, no, thank you so much for sharing, Gerard. I think we touched upon the question of training in our initial slides, and I don't want to take up too much time except to say that there is a lack of training in these settings, but there's also a lack of equitable training in these settings. And so it would be great to learn about your work later, but we can connect at another
Yeah,
time.
no, we can definitely connect. We've done a lot of work in other settings. Like we work very closely with Infection Control Network Africa, and we've done a lot of work in Zimbabwe and South Africa and other countries in Africa as well. So it's not just a first world technology.
Yeah, thank you so much. Thank you.
Sure. And if there are any links that you can share as well, maybe we could include those as sort of supplemental links as well when we send out the follow-up materials, just to add in another perspective there. I know that we're at the top of the hour. I think this question on ethics is still a big question, and we'll certainly continue to look at that and continue to have these types of discussions. But I do want to thank you all for a fruitful discussion today, and a special thank you to our speakers, Na, Neoshia, Arshmin, and Rashab, for sharing your experiences. This is still, an emerging area, and it was great to hear this example from Quicksand to just sort of spur this conversation around this larger issue of use and ethics of AI for behavior change. Just to quickly follow up, we will aim to send follow-up materials via email over the next week, and a full event summary will be available on the Global Hand Washing Partnership website in the coming weeks. But again, I just want to thank you all for joining us today. We'll continue these events and discussions in the future. So if you are interested, please join our listserv at globalhandwashing.org. But thank you all again, and hope you have a good rest of your day. Thanks, everyone.
Thank you, and thank you, now.